introduce to the audience someone at a much earlier stage in their career. And that's not to say that our next speaker doesn't have vast experience in the subject that he's going to speak about. So Dr. Aaron Baggish is the director of the Massachusetts General Hospital's Cardiovascular Performance Program, which is the first program in the United States specifically designed to deliver comprehensive cardiovascular care to athletes. Dr. Baggish is a fellow of the American College of Cardiology and the American College of Sports Medicine. He serves as medical director for the Boston Marathon, and he's the team cardiologist for US Rowing, US Soccer, the Boston Athletic Association / Adidas Elite Runner Program, for Harvard University, for the New England Patriots, and for the Boston Bruins. His research interests include exercise-induced cardiac remodeling, pre-participation screening for cardiovascular disease and sudden cardiac death prevention, and the cardiovascular effects of anabolic steroid use. He's very active in research and currently maintains independent research funding from the National Institutes of Health, from the American Heart Association, from the NFL Players Association, and from the US Department of Defense. And Dr. Baggish emphasized that his program provides consultative and longitudinal care for athletes across the spectrum, not just from Olympic level athletes, but right down to recreational athletes. And so for this audience, we've invited him to speak on heart disease, athletes, and the weekend warrior. So Dr. Baggish.
Thank you, David, for that kind introduction. I'd like to begin by thanking the conference organizers for importing me from your southern neighbor. It's a real pleasure to be here. We're going to make a move from the hyperdynamic state of pregnancy to the hyperdynamic state of exercise. And although there are a number of different topics I could have chosen to address this morning, I thought I'd take the bull by the horns and address what is probably the most contentious topic, perhaps even across all of the disciplines in cardiology right now. And that's whether exercise, which is something that we know is incredibly good for the body, probably the most important medicine we can prescribe to our patients, actually can reach a level where it does more harm than good. So how do we know what affects our patients' lives from the perspective of medical science? I would submit that if we move beyond the peer-reviewed journal and actually look in major news media syndicates, the New York Times, the LA Times, the London Times, and see what these people are writing about and see what our patients are reading, we'll know the questions our patients are asking. And it's interesting, over the last 5 years, the single most common topic that relates to cardiovascular medicine in the general media has been this issue of whether you can over-exercise yourself. So I'm going to try to present this topic with as much equipoise as possible. I want to just preface this by saying there are a lot of unanswered questions in this field, and I'm going to give you my views and my synthesis of the literature. So here are, for transparency's sake, some affiliations and some funding sources. And I want to begin by showing you some statistics, which should come as no surprise. Whether you talk about young athletes at the university level, older folks that participate in road races, triathlons, or gym-based activities like CrossFit, the number of folks that are turning to organized, competitive, and/or high-intensity recreational activities has never been higher in the developed world. There are a number of reasons for this, but these people are out there increasingly so. And one of the most important things to take away from my talk this morning is that exercise, even the healthiest dose of exercise, and we can agree to disagree what that is, does not confer complete immunity to cardiovascular disease. So if you practice in any way, shape, or form, you will be seeing active athletic patients come through your practice, and we'll talk about some of the diseases they may have. Does anyone remember where they were on November 27th, 2012? Probably not. I don't remember that evening, but I certainly remember the next morning. I showed up at work to 465 emails in my in-basket, and they were all based on this editorial that was published in the Wall Street Journal the previous evening, "One Running Shoe in the Grave." And the summary of this editorial is that running can take a toll on the heart that essentially eliminates the benefits of exercise. Running too far, too fast, and for too many years may speed one's progress toward the finish line of life. Bold words. This editorial was based on a soon-to-be-published medical editorial in the British journal Heart, and indeed here is that editorial written by two well-known U.S. cardiologists, Jim O'Keefe and Carl Labby, and the title of this paper is "Run for Your Life at a Comfortable Speed and Not Too Far." And this editorial relies on 4 lines of evidence: some reevaluation of some old epidemiologic data, some new studies looking at cardiac damage and dysfunction in high-level athletes, case reports of people dying during athletics, like this gentleman here, Caballo Blanco, who was the protagonist in the book Born to Run, and then some new emerging epidemiology focusing for the first time on the very high ends of fitness and high ends of exercise. Unfortunately, although this is an entertaining editorial, if you look closely at the science put forward, none of it really holds much muster. It is actually a very good example of the danger of non-peer-reviewed editorials. And you can see here, as transparently admitted by the journal, it's a commissioned, only internally peer-reviewed thing. If you are interested in this topic, the TED Talk is actually excellent, although unfortunately a lot of the science doesn't stand the test of scrutiny. But I do think that for the most part, where there's a lot of smoke, there's usually at least a little bit of fire. So I think as responsible clinicians, it's important we ask this question: does too much exercise over too much time hurt your heart? And I would submit, importantly, affect morbidity and mortality. And if so, what does this pathology look like? So to begin this discussion of exercise dose, I want to return you to one of the fundamental things that most of us learned in our clinical training, and that's the concept of the dose response. So dose response can be defined by two curves, an efficacy curve and a toxicity curve. And when we give our patients any medication or prescribe any intervention, we hope that they end up here in the margin of safety. But as you know, in population-based science, people don't adhere to curves, and we have benefit outliers, people that get lots of benefit despite relatively little exposure, and people that get no benefit despite lots and lots and lots of exposure. And the same is true with respect to toxicity outliers. Lots of toxicity at low dose, no toxicity at so-called toxic dose. So when we start thinking about exercise, how does the dose response curve behave and what does it look like? Well, it turns out that dose response across exercise is a function of which outcome you're looking at, and there is no one dose response. And here are 4 examples of how this looks. Curve A, the straight linear curve, is probably a good dose response explanation between exercise dose and race performance. The harder an athlete trains, the more likely they are to compete at a successful level and win. Curve B is actually a good dose response curve for looking at the relationship between cardiovascular risk factor improvement and exercise. When you go from doing something, or from nothing to something, you make big headway with respect to changing cholesterol, blood pressure, obesity, but there's an asymptotic part of this, and above a certain level of exercise, you're not going to do more for your risk factors. This complicated bimodal curve here is actually a good way of explaining the relationship between exercise and weight loss. You can stimulate weight loss when you start moving from a sedentary life to a little bit of exercise, but in order to really generate sustainable, meaningful weight loss, you have to do quite a bit of exercise, well above physical activity guidelines. And then, of course, the bell-shaped curve, which is my favorite, which describes the relationship between exercise dose and marital success. The more, if you exceed a certain level and you're not home, your spouse will give you up. So exercise and outcomes are very complicated, and we need to be careful when we're talking about how much exercise is good versus bad, that we know what we're talking about. For those of you that have no interest in sports and exercise and athletics, this is the single most important slide in the talk, and this is an algorithm put together by one of my junior colleagues and I, published in Circulation about a year ago, thinking about how to approach exercise dose at every single clinical visit with every single patient. I'll remind you that at least in the U.S., Human Health and Services recommendations recommend 150 minutes a week of moderate intensity physical activity, or the equivalent of 75 minutes a week of vigorous intensity physical activity. And so what we have espoused in this paper is the concept of assessing physical activity habits with every single patient at every single visit, regardless of their level of health or illness. And in doing so, you can place patients into one of 3 categories: those that fail to meet physical activity guidelines, those that meet guidelines, and those that exceed guidelines. Certainly in general clinical cardiovascular practice, folks in the red box here represent the vast majority. And as clinicians, we there have an opportunity to dramatically improve health and longevity by talking to them about the risks of sedentary living and then working with them to address barriers to getting more physically fit. Folks that actually meet physical activity guidelines are unfortunately the significant minority, and here when they are recognized in practice, the goal should really be to reinforce, motivate, and to give them a lot of positive feedback. And in the practice I run, we spend most of our time with this yellow box athlete, which are these people that routinely exceed physical activity guidelines, oftentimes by a fair bit. And here, and for the rest of the talk, the question always comes up, am I getting too much of a good thing? Is it possible for me to hurt myself? So what I want to do is I want to ask 3 very specific questions, and that is, do endurance sports cause arrhythmia, cause cardiomyopathy, and perhaps the most interesting, do they cause coronary disease? And I want to emphasize that I've underlined the word cause here because what we're going to be looking at are causal relationships. What's important here is cause and effect, not association. So let's start with this. This is a 52-year-old marathon runner who presents to your clinic with decreased exercise tolerance. No diagnostic dilemma here. This individual has atrial fibrillation. There are now a number of well-done cross-sectional observational studies which all reach the same conclusion, and that is that men and women that push their bodies hard into the 5th and 6th decade of their lives are at increased risk of atrial fibrillation. Every single masters athlete population that's been studied has this same finding, and so it's actually, I think, quite well accepted now that this is one of the risk factors of exercising at high intensity and high volume as we get older. Probably the most elegant of these studies comes out of Northern Europe. This is a study out of Sweden, which examined participants in the Vasaloppet, which is a 90-kilometer ski race held there every year. And over about a decade and studying more than 50,000 participants, the authors asked the question, how often these men raced and how fast they raced, do they predict incident arrhythmias? And it turned out both of those attributes of exercise dose were predictive. So the more dedicated these athletes were and the better they were, the more likely they were to go on to develop arrhythmias. And the vast majority of this was atrial fibrillation with some flutter mixed in. So why does it happen? Why do fit people as they age get atrial fibrillation? The classic and probably easiest to understand pathogenic explanation is that the left atrium dilates, and with dilation comes the propensity for arrhythmia. But it is much more complicated than that. There is remodeling that occurs, but more importantly, there are neurologic issues, persistent vagotonia sprinkled with sympathetic surges during exercise, intermittent left atrial hypertension, chronic inflammation, which I would submit as one of the least well understood aspects of the exercise dose paradigm, certainly host factors like genetics, alcohol, caffeine, and psychological stress. At this point, the strongest association between endurance sport and pathology does lie with atrial fibrillation. Now, the data are quite clear that our aging patients who engage in these sports are at increased risk. What I don't think is entirely clear is how much of this is sport versus lifestyle. This is something that needs to be teased out. But the real challenge in clinical practice is we have absolutely no data to guide ourselves with respect to treating these people. Everything we do is an extrapolation of what we know about treating more sedentary people with atrial fibrillation, and I would submit that decisions around medical management with respect to sinus maintenance versus rate control, anticoagulation, the decision to proceed to catheter ablation are very, very, very different in people that push their bodies very hard. And so at this point, we rely on expert experience, we rely on anecdotes, we do not have randomized control trial data to help us. I suspect this will be one of the biggest advances over the next decade, is that as this population of aging active people gets studied in more detail, we'll have some answers here. As for right now, still very much dealer's choice. So what about cardiomyopathy, problems with the heart muscle? We have had now for the last decade a program in Boston called the Harvard Athlete Initiative, where we've leveraged our student athletes to understand things that happen to the body with training intensification. It turns out that freshman university athletes are the ideal group to study with respect to understanding cardiac plasticity. They've done enough exercise to be able to withstand the rigors of college level training, but they've never yet seen that volume and intensity before. So what that means is that we have a precious period of time to look for cardiovascular adaptations, and they occur right in front of our eyes. One of the very early studies we did was this strain echocardiography study, where we took a group of male rowers who were about to prepare for an intense 90-day period of training in preparation for the Head of the Charles, which is a big rowing race in Boston held every year. And we asked the question, does systolic function, contractile function of the heart, change as these men get fitter and their hearts enlarge? And so we applied strain echocardiography, which most of you know is a way of looking at how well the heart muscle tissue shortens to these young men. And we developed strain maps, and these are what strain maps look like. They quantify fiber shortening and the three principal vectors of cardiac deformation, the longitudinal vector, the radial vector, and the circumferential vector. And what we found for the most part was no surprise and somewhat reassuring that in most of the areas here represented in various shades of gray, that as these men got fitter and their hearts got bigger, that contractile function improved. But there was one exception, and that is within the interventricular septum, so the heart wall that divides the left and the right ventricle, we saw a reduction in strain, and this looked like a fatigue signal. So it was interesting as we step back and ask why this might be the case that we noticed that the folks that had the most septal fatigue were also the folks whose right ventricles got the biggest during training. So something about right ventricular dilation was impacting the ability of the interventricular septum to contract. So big deal. We wrote this paper. We had absolutely no idea what this meant clinically. We put 2 lines in the discussion saying this is probably a red herring. We have no idea what septal fatigue means. This is probably something we shouldn't care about. Until about a year later, I got a call from a gentleman by the name of Greg White, who's a physiologist working in the UK, to tell me that he had put together a small cohort of masters athletes, and he had done cardiac MRI on them. And lo and behold, in a small group of these people, he saw non-ischemic fibrosis, so scarring in the heart muscle, in exactly the same place that we had seen septal fatigue in younger athletes. And so his hypothesis was that perhaps this fatigue signal that we see developing in people that are 20, 21 years old, if pushed hard over many years, many decades, can actually translate into a scar pattern. That paper that Greg published was followed very shortly thereafter by a very nice study done by André Lagersh, who was working in Belgium at that point, and I want to walk you through André's study because it remains the best study we have looking at this issue of heart scarring in athletes. André took 40 trained, very, very fit athletes who were all good. They were competitive. They were finishing in the top of their age group in endurance events. They were all asymptomatic, and none of them had traditional risk factors. He looked for inducible ischemia before study and found none, and then studied them with cardiac MR, echo, and biochemical analysis at 3 time points: before a race, immediately after a race, and then after some period of recovery, roughly a week down the road. Here are the folks he studied. They were marathon runners, endurance triathletes, alpine cyclists, some ultra triathletes, and I will call your attention to the 3rd line here from the bottom, and that is their % predicted VO2. These are fit people. So a % predicted VO2 ranging from 140 to 160. These are definitively competitive athletes, many of whom had been pushing hard for many years. So what happened to them when they went out and did their big race of the season? Well, not surprisingly, there was clear evidence of physiologic perturbation. Their post-race heart rates were up, their systolic blood pressures were down, their pulmonary artery pressures were down, and at the level of the myocardium, the right ventricle seemed to be preferentially affected. So there were decrements in systolic function, there was dilation of the right ventricle, and this schematic illustrates that quite nicely. What he found is that there was a dilation of the RV with shift of the interventricular septum into the LV cavity, and that this, when looked at by cardiac MR at follow-up, had pictures that looked like this. So non-ischemic patches of fibrosis in the interventricular septum with the propensity to co-localize at the RV insertion hinge points. This was a very provocative finding. Again, the healthiest segment of society developing fibrosis in their hearts for no other reason than perhaps the type of exercise they do. I will say that this is preliminary. I think it's preliminary to suggest that a small minority of chronic endurance athletes may develop this fibrotic myopathy. At this point, it's a phenotype of absolute uncertainty from a clinical perspective, one that we need to study more and one that we need to look at from an outcomes-based perspective. I see thousands of athletes a year, and I see very little of this, particularly with the presentation that we would care about, and that would be malignant arrhythmia. But again, this is something that's out there. How would this happen? Let's just step back and ask, if this does happen, how would this happen? And it probably looks something like this. Chronic extreme volume intensity, so lots and lots of exercise, coupled with training recovery mismatch, meaning not enough rest and recovery. Something at the level of the host susceptibility and probably something at the level of the DNA matters. It's not ARVC genes, that's been well vetted, but something else makes one person susceptible to this and the other not. But I would submit probably most importantly, there's got to be some secondary process. Illicit use of drugs, some suboccult infection, or perhaps just undiagnosed garden variety heart disease like systemic hypertension. But if this exists, I think it is possible to develop this perfect storm and end up with a heart looking like this. What does it mean? I don't know. We'll have to let time tell us. So finally, I think the most interesting of all, and that is, do endurance sports cause coronary artery disease? I do not need to remind this audience that when we talk about exercise and its impact on health, that it is the single best way to improve cardiovascular risk factors. It is imperative that we tell all of our patients, both in a primary and secondary prevention setting, that exercise is among the most important things they can do to keep them healthy. Why is that? Because exercise improves blood pressure profiles, it reduces abdominal adiposity, it improves plasma lipoprotein profiles. And what's fascinating, as we learned from this work by Samia Mora and Ayman Lee out of the Women's Health Study, is that even even when we account for risk factor modification, we only understand about 50% of why exercise makes people healthier and makes them live longer. So there truly is something magical, at least something still undescribed at the biochemical level that's good about exercise. And so all of our patients really need to be moving, getting up. Sedentary activity is the single biggest public health crisis we face in the developed world in 2017. So where does a study like this come from? Running the risk of coronary events, prevalence and prognostic relevance of atherosclerosis in marathon runners. This was a study published now about a decade ago out of Germany, in which roughly 100 men above the age of 50 who were dedicated marathoners were studied with coronary CT scoring. And what the authors found is that these men, when compared to risk factor matched and age matched controls, had more coronary calcium. And indeed, when these men were followed over a period of time, the folks with the high level of calcium went on to have events that we as clinicians would care about clinically. Second study, this one from the Missouri Medicine Journal, admittedly not one I read routinely, but it was one that was published in the US a couple years ago, and this is entitled Increased Coronary Plaque Volume Among Male Marathon Runners. And here again, men in their 5th decade of life who had run a lot. These men had all run the Twin Cities Marathon 25 times consecutively, so a lot of running. Were studied again with CT coronary calcium scoring, and this time CT angiography. This study is problematic because there's a lot that was left out. There's a lot we don't know about these men. We know nothing about their training history, nothing about their race performance, nothing about their physiology. But lo and behold, a similar finding to the German study, and that is that the marathon runners had more coronary artery disease, specifically as defined by calcified plaque, than those that didn't race. So when you see studies like this, you're left with 3 interpretation options. One is that, and this is the easiest, laziest explanation, the one that the authors in this paper took, and that is that high levels of exercise simply cause atherosclerosis, that if you exercise a lot, you're going to stimulate coronary disease. Very counterintuitive to those of us that take care of patients, but it's plausible. Additional interpretations include, 1, traditional athero risk factors are indeed causal, but they were simply underappreciated in these studies, or perhaps most fascinatingly, that coronary disease in fit people may be driven by unknown, unmeasured risk factors, and maybe it's even a more benign phenomenon than it would be in someone that was sedentary. So let's go back to the German study and again ask this issue, try to address this question of whether or not we think their coronary disease was caused by their running. So remember I told you there were 4 men that went on to have events, and these were 4 men that had high coronary calcium scores. Here they are. First thing to note is that these are indeed accomplished marathon runners, 14, 22, 65, 140 marathons. That's a lot of marathon running, let's be honest. But who were these men? Let's look under the hood. Male 1 had a total cholesterol of 344 and was a former smoker. Runner 2 was a diagnosed treated hypertensive. Runner 3 and runner 4 were both untreated, unmedicated hypertensives who were both former smokers. So you really think it was the running that caused these men's coronary disease? I suspect probably not. What about in the Missouri Medicine study? Similar thing. They were able to look at this group of accomplished marathoners, and indeed more than half of them were former smokers. And in order to make former smoker status in this paper, you had to have smoked at least a pack a day for 10 years. So that's quite a bit of smoking. So, you know, it's difficult to think that running was the issue here when you're dealing with a lot of former smokers. And what this paper really identifies are some of the missing issues that are consistent across a lot of the exercise epidemiologic literature, and that is there's no attempt to account for the impact of diet. The diet that fit people eat versus healthy diet are often very discrepant. There's this concept of being able to burn anything you put in the furnace if you maintain weight, but indeed macronutrient choices make a big difference with respect to vascular health. There's what I term the carefree 20s and 30s. Many men and women that turn to exercise as they age do so out of a recognition that they made some unhealthy choices early in life. And while becoming fit and active later in life is certainly an admirable thing we should support, it doesn't completely erase bad choices earlier in life. And then family genetics. How many times do we see people that turn toward an active lifestyle later in life because they realize that a parent or a sibling developed premature atherosclerosis without any good explanation? And so without controlling for any of these, I think it's very difficult to say any causality conclusions. To bring this home and to really kind of talk about who this population is that we've been thinking about this morning, I want to take you to a place that's close to where I live in New Hampshire in the United States, and this is Mount Washington. Mount Washington is one of the highest hills in the East Coast in the United States, and there's a road race that they have up this mountain every year, and the contour looks like this. They like to say there's only one hill, and indeed that's true. It's roughly about 4,000 vertical feet over 7.5 miles, and a couple years ago I took one of my sports cardiology fellows up there because she wanted wanted to learn about endurance athletes. And I said, just come with me to the race, keep your ears open, and you're going to hear conversations that really inform you about who these folks that we take care of in the clinic are when they're not at the hospital. So we arrived at this race and got in line for the porta potty, because that's what all athletes do before a race. And a conversation erupted in front of us, which I would have paid huge sums of money to be able to audio tape. But let me play the conversation out by my memory. There were 4 men, approximately 50 years of age, who were waiting for the porta potty, and here goes the conversation. First guy says, "Man, not so sure that second plate of chili nachos and the extra couple of beers last night were such a good idea." "Oh well, they always say don't change your routine prior to races." So again, any questions about the dietary issues in this population? Runner 2, a little more sobering. "Just wish my old man could see me now. He died at age 45 from a massive heart attack. Glad I got my wake-up call. Bad stuff runs in my family." Now this is an admirable acknowledgement of the fact that genetics are working against him, and he's trying to do things to reduce his genetic risk. But again, when we see these patients clinically, we have to remember that there's no amount of exercise that will permit one to run away from genes completely. Well, regardless of what happens, I've got to be better off than I was 20 years ago when I was smoking a pack a day and just got short of breath driving up this damn hill. So again, this is someone that's making, again, a very admirable decision to turn his life around, and we want to support this. But when we think about risk and causality, we can't throw this out of the calculus equation. And then finally, the best one, cough, 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 sputter. "If this race wasn't only once a year, I'd be home in bed. I feel like shit. Oh well, this little climb will help me clear out the junk." This is an athlete making the decision to run 4,000 vertical feet over 7 miles in the midst of a viral infection. Bad idea. Remember, when our nares and our oropharynx are inflamed, so too is our entire vascular tree. And if there's ever a time for acute plaque rupture to occur, this is it. And we take care of hundreds of men and women who have had cardiac arrest during running or other forms of endurance activity. And one of the most common things we learn from them and their spouses is that there was some antecedent viral infection. I don't have hard, fast data to prove this, but it's a story that comes up over and over again in our clinic. So is running really the main causal issue? Probably not. It's probably the attributes that our athletes bring to the equation. Let's go back to this dose-response curve and put this all together. So again, remember efficacy and toxicity, and in between lies a margin of safety. Perhaps the most important thing to remember about fit people as they age is that most of them, the vast majority of them, are going to be in the margin of safety. They're going to derive all the benefits of physical activity, health benefits, psychosocial benefits, and they're going to do so for the rest of their lives and never have any problems. Coronary disease lives in this margin of safety, and my synthesis of the literature is this has nothing to do with too much exercise. It has to do with what people in this population bring to the equation from a risk factor perspective, some traditional and some we still don't understand. Atrial fibrillation represents the single most important example we have of use-associated pathology. This is the one thing that our masters athletes are at an increased risk for, and again, I submit that we have a lot to learn about treatment in this population, and hopefully data will soon be coming that will help us in this vein. This issue of toxic exposure cardiomyopathy, I don't know what to make of it. Again, we don't see a lot of it clinically. There is some preliminary data that suggests that it's out there, but what we really need and what hopefully we'll see in the next 5 to 10 years are some outcomes associated with this phenotype. So in the absence of a lot of hard, fast data, our patients still come to us with questions and they want answers. And so what we typically do is we approach this with our 7 rules of common sense. And in my last minute here, I want to leave you with the instructions and the advice we give to our aging athletic patients. Number 1, and this is more for those of you who are clinicians in the room rather than those of you who are athletes, and that is to address cardiovascular risk factors. The single biggest mistake we can make with a man or woman that looks very healthy that walks into our office is to ignore a blood pressure of 140/90 or an LDL cholesterol of 170. If we don't treat these things, and treating doesn't necessarily mean jumping right to high-gun medications, but if we don't address these things in one way, shape, or form, they're going to catch up with our patients and they're going to develop the heart diseases we're working to prevent. Discussing health and performance. All of my patients run marathons and do triathlons, but I've never once told someone they need to do those things for optimal cardiovascular health. Simply meeting routine physical activity guidelines is the only necessity, and this is the message we should send to people. If they want to do more, I see no reason to discourage them if they do it safely, but they don't need to do it to stay healthy. Annual periodicity. What do I mean by this? I mean building in rest and recovery. So we typically recommend our active folks take at least 3 months out of the year in a phase of active recovery, which we define as a reduction in both volume and intensity by at least 50%. This is good for healing the body, but also good for healing the mind. Prioritizing warm-ups and cool-downs. We haven't talked about sudden death during this morning's lecture, but most of you know that it happens and that exercise transiently increases your risk of sudden death. All of the sudden death cases that have been studied occur on the shoulders of exercise. So within the first couple minutes of starting and within the last couple of minutes of finishing. If our patients learn how to warm up and cool down correctly, we'd make a big dent in this problem. Event preparation, it's impossible to get up and do something without preparation, and indeed preparation becomes even more important when you're co-managing medical illnesses, so we spend a lot of time with our patients talking about medication changes, timing of intervention around events that they may be preparing for. Respecting a virus, I think I made this point with the cough, cough, sputter, sputter guy. It's okay to exercise at low to moderate intensity levels during viral infections, but it's a terrible time to go out and push intensely. And then the single most important thing to really share with all of our patients, and for those of us to think about for ourselves, is to listen to warning signs. If your body becomes unable to do something that it was able to do easily 3-6 months ago, that needs to be considered cardiovascular disease until proven otherwise. So I'm a few seconds over. I apologize for that, but I'll conclude, and I appreciate your attention.
Okay, well, thank you very much, Dr. Baggish, and I'd like to invite all three of our speakers, Dr. Huang, Dr. Su, and Dr. Baggish, to come to the front. And because our speakers have kept nicely to time, we've got about 30 minutes or so, 25 minutes, where we can have an interactive discussion. I've got some questions here, and again, there's the opportunity to approach the microphones as well. So I'll maybe ask a first question, then I'll go and take my place also on the podium. And I'd like, just to our first speaker, there was something that Dr. Huang mentioned on the way through about the resources that he's made available with his presentation on the website. So it's a non-content related question, but could you just go over again for the benefit of our delegates the resources that you've put on the website?
So the file that I included as extra material, you'll see PDF copies of the Mini-Mental, the MoCA, various versions of the MoCA, the RUDAS tool, cognitive forms so that you can print them, keep them handy, also the scoring, the implementation, all that stuff for reference.
Okay, thank you very much, Dr. Huang. And a supplementary question from the audience. Someone's mentioning as a frailty index, they like the modified Rankin Score. And do you have much experience with this, and how do you feel it compares to the other scores that you mentioned?
I haven't heard about the Rankin Score for a long time. So again, function, frailty will impact on function, and function impacts or gives you a frailty measure or presence or absence of frailty, so that whatever you use to measure somebody's functional ability or ADLs, both basic and instrumental, will give you a sense of frailty. But I think that if you use a frailty specific assessment tool, it may give you a better sense of a global functioning.
Okay, so frailty is only one of the measures that you would assess in your practice. Okay, maybe we could take a question from the floor.
Thank you. My question is for Dr. Baggish. Thanks for an excellent talk. You talked a lot about high performance, high endurance athletes in middle age. I was wondering if you could comment on the risk of coronary disease or arrhythmias in the true sort of weekend warriors that we see in the office that are quite sedentary throughout the week, and then will do, say, play hockey once a week with intense shifts and then on and off.
Yeah, so the question is about weekend warriors, and I didn't focus on that too much. You know, weekend warriors, the term weekend warriors has actually kind of become associated with very negative connotations, but it turns out that if you look at the health impact of exercising just on the weekend, it's actually substantial. So when people come to us and they say, I don't want to exercise from Monday through Friday, I exercise on the weekends, is that good? I say, well, it would be better if you exercised a couple times midweek, but if that's all you can do, something is better than nothing. The big challenge, as alluded to, is many of these men and women and try to stack it all into Saturday and Sunday, and they do so with lots of high intensity. And that's probably not a great idea. Volume would be better than intensity, particularly if you only do it once a week. Their risk of developing heart disease and their risk of having problems is, I think, a function of two things. Again, it's their basic risk factor profile, and it's the way they approach their exercise. So if they're smart and they understand how to warm up and maintain activity and cool down, and they do this responsibly, I think there's no reason to discourage the weekend warrior profile. If they don't follow those types of approaches, I think they very much run the risk of having bad events, and we should work with them to mitigate that risk.
Okay, thank you. A question for Dr. Sue. It's quite a specific question, Sam. Should a pregnant woman label or limit her intake of caffeine?
There's always a concern when women start having arrhythmias or palpitations about caffeine intake. They're really within reasonable limits. There's really no relationship between caffeine intake and arrhythmia and palpitations, and we usually don't get concerned over it. Now, if somebody's drinking huge amounts of coffee or caffeinated beverage, that's an issue. But most normal intake of caffeine is not an issue. And many women, by the time they come to you, will have already self-limited to their caffeine intake if they start having palpitations. And usually that has a negligible effect on their symptoms. Yeah.
Thank you. And our questioner.
Thanks very much for Dr. Baggish. I'm a hospitalist. I do admission histories and physicals, and I routinely ask a question about exercise. Often from a younger person, I'll get an answer such as, I'm a framing carpenter, I work construction, I'm a landscaper. Is there any assumption that this constitutes exercise?
Yes, so it's a fabulous question, and what you're getting at is whether there's any difference between physical activity and exercise. And the answer is we have no idea. One would assume that occupations that engage in physical activity would be healthier than occupations that do not, but how to educate our patients about the relative benefit of that compared to traditional exercise regimens is a completely black bag. I'll tell you that for the most part, when people tell me they get enough physical activity either on the job or at home because they rake leaves or cut logs, I tell them that's probably not sufficient and that they should build in physical activity in the form of routine exercise as part of their regimen, but I can't point you to a literature source to substantiate that because it just doesn't exist. Now that's going to change. In the era of wearable devices, many occupations that require physical activity are now getting studied and getting studied quite well. So I suspect in short order we're going to have some outcomes data linked to physical activity as a function of occupation. But right now, no idea.
Okay, a question really for all three panelists with sort of respect to their individual separate populations. We'll take them in turn, starting at the far end of the table. So doctors are often perceived to be paternalistic, though this has probably changed with time. We know that the compliance of patients requires patient engagement, and whether that's the patient or their close relatives, for example, in the older patients, what steps can you take in your practice, or can you give us any advice about how to engage in a contract of care with the patient to improve compliance?
Well, I guess I've got a simpler answer, and if you use a tool that you ask the patients to complete, or the patient and their family member or whoever they came with to complete, then they're reflecting on themselves, what they're about, and prepares the discussion between them and yourself in terms of what's happening medically and what are potential interventions, so that you turn the model around to be much more patient-centric and to engage in what matters most to the person themselves. So I have it a little easier.
We are very much in the area of patient engagement, and we've been doing it for many years, and I think that's our expectations, our role as practitioners. When I provide risk assessment and counseling, I'm very careful not to be paternalistic to tell patients that you're at high risk, you shouldn't get pregnant. My role is as an advisor, as an educator, and in patient care, as is in life, relationship is everything. So I think the important thing is that you have to establish that some degree of mutual trust and respect, that the patient should feel free to refuse your advice or not to take your advice, and you still will look after them. And once, even somebody's very high risk that we've told that this may be not a good idea to go for pregnancy, and they're pregnant, okay, you make that decision, we'll look after you, and that's the end of it. We don't revisit that issue again. And most of our patients come, because I do adult congenital heart disease as my other line of work, most of them come with parents, many of them, almost all of them come with partners or relatives. It's very much as a family consultation. And so everyone's invited. I don't kick anybody else and just talk to the patient. And at the end of the discussion, two things that I do. I say, is there anything else that we haven't addressed or you have concerns about? To give them a chance to sort of ask any other questions that hadn't been addressed. And number two, I always, in my practice, and that comes from my training at the Mayo Clinic, where lots of patients are self-refer, the patient has a copy of my consultation. So in other words, I'm not going to say anything that's going to be a surprise to the patient. I say it's going to be written. If you don't agree with it or my wording is incorrect, feel free to call me. Some people will call me and go, I'm not a former smoker, I'm a non-smoker. It's just a typo that I made. So you keep that relationship open. At the end of the day, it is a relationship that you try and follow. And I think this helps compliance. It also keeps you out of trouble.
So I really like that answer, and I'm struck with how many parallels there are between what you do with pregnant women and what we do with high-risk athletes. Probably the most challenging compliance issue we deal with is the issue of sports eligibility after a heart diagnosis. And as most of you know, historically, the document that we've relied on to help us figure out whether an athlete with heart disease can play or not is the Bethesda Conference Proceedings, which is now about 30 years old. That document historically has been very, very paternalistic. It's been very binary. It's all yes, no. And that document hasn't served us too well. So we updated that about 2 years ago, and it is now published in the form of an ACC-AHA guideline or consensus expert recommendation around sports participation with heart disease. And the guideline now clearly endorses a shared decision-making process in which athlete, parents, if they're of the appropriate age, and all of the other stakeholders come together after a diagnosis has been made to figure out the best fit for that individual. And this is complicated. This requires long conversations, oftentimes many office visits. But at the end of the day, if the patient is able to, with the physician, steer the ship and make decisions that work for them, we find that our compliance, and again, I'm using the word compliance to talk about following recommendations that are provided, is much, much better. This is a big change in the way we practice, and it's something that I think we're only starting to realize the impact of with respect to outcomes and patient satisfaction.
Okay, thanks to all our speakers. Perhaps we could come to the floor microphone.
Thanks. So question for Dr. Baggish. I suspect there are no good studies comparing, in endurance athletes comparing the main fuel that they use, sort of, I'm thinking of switching from carb loading to fat. And my concern is, I kind of worry about endurance athletes at carbohydrate load because the glycolysis cycle it seems inefficient. It's got all sorts of byproducts, more reactive oxygen species, more acidity. So I wonder if you could comment on that.
Yeah.
Thanks.
It's a great question. So let me start by just saying very transparently that I think in medicine in general, not just sports cardiology, but in medicine in general, diet represents one of the least well understood parts of what we can do for our patients. And if you get a panel of dietary experts together, none of them can agree on anything. So it's fascinating. Carbo-Loading, which is the age-old practice of athletes ingesting huge quantities of carbohydrates before events, is a leftover vestige of the old food pyramid, which recommended that most of our calories should come from carbohydrates. Not only do I think that's not healthy, but I think it's been shown quite convincingly that that doesn't actually improve performance. So we've moved away from recommending a carbohydrate-rich diet and recommending more of a balanced diet and really focusing on carbohydrate sources. So anything that's been refined, anything white, bread, rice, pasta, any of that stuff needs to be removed from the diet and replaced with whole grains. I think carbohydrates are an important part of a balanced diet, but they shouldn't represent the bottom of the pyramid.
Okay, and we'll come to this microphone.
Thank you. Thank you, Dr. Huang, for your talk. I was interested in what you said about using the frailty score, the high frailty score, and deciding about advanced procedures for those people. It occurs to me that perhaps some of what they need the advanced procedures for is adding to their frailty score. I'd like you to expand on that and on the whole idea of choosing who's going to get advanced procedures based on that.
Well, I think that the main issue is if you identify frailty, whichever domain it is in physical, but the cognitive especially, because it is hidden, that should factor into the discussions what it is that the person's coming for specialized attention, what can that specialized intervention offer. Is the benefit of that intervention, let's look at TAVI, for instance. They're all old when they're coming to TAVI. But if they're a 92-year-old who's moderate to severely demented versus mildly demented, you look at what is their lifespan. Are they going to have enough of a lifespan to reap the benefits of that new valve in them, because they're coming to you because of heart failure or had a syncopal episode, etc. So it just modifies that discussion and makes them aware, saying, okay, perioperatively, you're going to have a delirium, 100%. That may land you into a bad place. You came from home. You may never return home. Is that what you want your path from here on till the end to look like? So you can give them alternative pathways.
Thank you.
Okay, thank you. A question for Dr. Sue. Sometimes if you have an expert, it's a good way to get an answer to a quick question. So obviously we know pharmacology and the product literature that comes with every medication we prescribe, but one of our audience wants to know, are there certain medications or agents that are specifically indicated or contraindicated, in pregnant patients that we would commonly use for the treatment of heart failure or for tachyarrhythmias?
The big bad ones that you need to think about, ACE inhibitors and ARBs, and those have been associated with renal agenesis. That's the two main ones, and very high dose warfarin, that is associated with embryopathy, although dose of less than 5 milligrams have a lesser risk, but it's not zero. So the main bad ones are ACE and ARB. I usually have a slide on this. Other relative contraindications, also dilantin, because of it's also teratogenic. People also mention amiodarone and nitroprusside, which is not something that's usually used in the office, but that can be used in an emergency. So the big contraindications are ACE and ARB, which is used for heart failure. Less is known about things like mineralocorticoids, and usually Lasix is fine, beta blockers is fine. We try to stay away from atenolol, which has been reported to have in high dose to cause a reduction in mean fetal birth weights. But we used to use other things like metoprolol, something short-acting. Bisoprolol is fine. So the heart failure medications that you got to stay away from is ACE and ARB. And as soon as as long as you stop it early in conception, before 6 weeks, the risk to the fetus is minimal.
Okay, 2 questions from the floor. Maybe we'll take this microphone first, and then.
Dr. Baggish, could you comment on the use of replacement fluids during the exercise and the use of Gatorade in particular before, during, and after?
Sure. So the question was about the use of replacement fluids. We never really thought much about replacement fluids, particularly too much replacement fluids, until the advent of exercise-induced hyponatremia, which is an over-ingestion or a fluid drowning syndrome, which develops because of excessive free water intake. You have to replace fluids if you're exercising for long periods of time. You can certainly under-replace and you can certainly over-replace. Typical recommendations now are to drink to thirst and to start early. And I think it makes sense if you're exercising, particularly in warm conditions, to be ingesting something that has electrolytes in it. Whether you choose a commercially available product that has both electrolytes and sugar, I think it's just something you have to experiment with to see how your gut handles it. There are a number of good non-sugar containing electrolytes fluids that are just as good from the perspective of preventing hypokalemia and hyponatremia. So I think it's dealer's choice. But on average, in normal exercising conditions, we'll say 65 degrees Fahrenheit, a marathon run, roughly a liter of fluid per hour is good for most people.
This question for Dr. Baggish. You touched upon high-intensity interval training. How does that compare towards the endurance athletes in terms of the cardiovascular benefits? And is there any literature kind of contributing to how that would affect your health into the older age?
Yeah, that's a great question. So the question was about high-intensity intervals. Most of the folks that, that you'll see that are trying to perform will include intervals in some way, shape, or form into their training regimen. It's simply required to run fast or cycle fast. You have to do high-intensity work. And if it's done in the context of a good aerobic base, it's probably not a big deal for people that are fit. It becomes much more interesting when we think about using high-intensity interval training therapeutically, particularly in secondary prevention populations, i.e. typical cardiac rehab. And although it would seem to be such a dangerous, risky thing to ask folks post-ACS, post-MI, to push themselves to 80-90% peak effort, it's looking a lot safer than we thought. There's a lot of good literature coming out of Northern Europe about this right now. And although I don't quite think we all know how to apply it in clinical practice yet, my sense is that there's going to be a paradigm shift in the rehab process over the next 5 to 10 years in which high-intensity intervals become a very viable option for patients that want to engage in that.
Okay, and actually two related questions for Dr. Baggish as well, both to do with screening. So Aaron, should screening be employed for high-performance athletes? And I think this is in terms of stress testing maybe, or screening for arrhythmias with Holter or 30-day monitors, in fact. So should screening be performed for high-performance athletes and for weekend warriors? And then related, is there an indication to do formal stress testing before anyone wishes to embark on informal exercise?
Yeah, I was hoping we'd get through this morning without having to do screening because it's a really controversial and tough topic. When we're talking about older folks, particularly a one-on-one interaction where someone comes to your office or your clinic and tells you they want to start an exercise program and they want to push hard, I think that's a little easier than talking about community-based screening of young athletes. And there, if they have any established cardiovascular risk factors or any symptoms suggestive of an underlying disease, they should be exercised, and they should be exercised to peak volitional fatigue, not terminated at some preset heart rate to look for myocardial ischemia, and I think that's quite clear. The use of ambulatory rhythm monitoring, I don't think there's any necessity to do that from a screening perspective. Clearly, if someone endorses subjective arrhythmia, it makes a lot of sense. If people want to talk about screening young people, and I know this is an incredibly difficult topic to wrestle with. Maybe we can do so in the workshop that's coming up. The CCS is actually working on a document for this right now, which I hear is fraught with controversy, no surprise. We've wrestled with this topic in the US for a long time, and we still can't agree what the best option should be.
Okay, thank you. If there's any further questions, please feel free to come forward. Now's your opportunity. I'd like to ask Dr. Sue, so this is a session billed as cardiac disease for special populations, but obviously there can be special populations within special populations, and pregnant ladies are a heterogeneous group. And I think you mentioned, Sam, that about 0.5% of ladies in Canada have established heart disease. But we know that there are perhaps distinct populations. I'm thinking of First Nation populations that some of the audience may be looking after. And as you know, I visit parts of the world where the prevalence of rheumatic heart disease in teenagers is perhaps 1 to 1.5%, and all of those pregnant girls are going to become, or those teenage girls are going to become pregnant ladies. So do you think there are unique challenges within distinct subsets of the population in terms of presenting preconception or presenting early for evaluation in pregnancy, and can you tell us what they are? Thanks.
I think what we see in pregnancy and heart disease, similar to what we see in the other special population, allocongenital heart disease, is that we in Canada are very privileged as a whole to have access to universal care for most residents in our country. And that's a privilege that many people do not have in other situations when there's unequal access. So some of the outcomes and some of the risk prediction rules that I presented today was based on mostly developed countries, and our Canadian outcomes have probably been one of the best, and we think it reflects the fact that the patients have access to care. There's an international study called ROPEC, which is people are concerned about the methodology because there's no validation of who the patients are and the outcomes, but they were showing very brief, broad strokes that the mortality and the morbidity rates in patients with heart disease, pregnant with heart disease in developed countries is much lower than that of developing countries. And even though most of the patients identified or enrolled from developing countries are going through tertiary care centers. So I think socioeconomic status, access to care, rural versus urban, these are things which sort of goes into the risk that we have not looked at, partly because it is difficult to derive these things using patient-level data, such as having a registry at a clinic such as ours. I'm actually ISIS Western scholar, and that's part of my research atmosphere, because as an epidemiologist, I think you always think about what is the global impact on what we do, at the patient level, it is important what we do, but at the global level, those of us who do this are doing it not because there's something, we're doing it because we want to make a difference, and we want to make a difference, in the biggest population. So I think those are unanswered questions. But getting back to the short answers, that those special population where they have limited access to care, either due to distance, due to socioeconomic status, income, of which we think, in theory, should be minimized in a system like ours, but we know in reality does not always occur. I think that's the next challenge of those of us who work with this. I call it, these are neglected populations. I think that's where we need to focus our research efforts on, because they will impact on policy and hopefully outcome.
Okay, well, if there are no further questions, we're 1 or 2 minutes ahead of time. I don't see anyone stepping up to the microphones. So maybe we will bring our session to a close there. On your behalf, I'd like to thank our 3 plenary #1 speakers, Dr. Huang, Dr. Su, and Dr. Baggish, for giving us very interesting presentations and leading an engaging discussion. The timetable for those physically in Toronto today is that we now have a nutrition break, which is going to stretch until 11:20. If you're joining us in the webinar, I'm not sure what's scheduled, but the next presentation for the webinar delegates will be projected from this ballroom at 11:20. It's going to be a workshop, I understand. Dr. Wolf's talking about managing diabetes in 2017, what to add, when, and why. So for those who are present in the room, we'll have 6 concurrent workshops. I would just say that if you're going to a workshop in Osgood, that's on the 3rd floor, and York is on the floor above us. And if you can try and be at your respective venues by 11:20, that would facilitate timely running of the programme. Thanks again to our speakers.
Nice to meet you. Sir.